Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question that you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble. In this summary version of 1 p.m., Dr. Will Courtney will be going through how you would approach the management of atrial fibrillation in an OSCE situation. Thanks, Will.
So if you walk into a patient who has atrial fibrillation, you make sure they're clinically stable by doing your A through to E. If during your A through to E, you identify on the ECG a lack of P waves and an irregular pulse, then you know what pathology you're dealing with. It's atrial fibrillation, okay? Your approach then is to go C, A, or C, treat the cause. Specifically in this section, mention ischemic heart disease, valvular heart disease, and thyrotoxicosis. And if you can remember, mention electrolyte disturbance, post-op patients, and infections. All right? Then move quickly on to anticoagulation. State that you would like to consider anticoagulation in all patients. You would do this by doing a CHADS-2 VASC score and also a has-bled score to make sure that they aren't at increased risk of bleeding when anticoagulated. If these scores permitted you to anticoagulate, i.e. your CHADS-2 VASC was 1 or more and your has-bled score was acceptable, you would then anticoagulate. You will generally anticoagulate with a NOAC. I would choose apixaban, 5 milligrams BD. There are certain patients who can't have a NOAC, patients who have a metallic heart valve, or patients who have valvular atrial fibrillation need to be anticoagulated with warfarin. Most other people are eligible for apixaban. After I've treated the cause and anticoagulated, I would now move on to considering either rate and rhythm control. In patients who have permanent atrial fibrillation, that is to say atrial fibrillation, which we are no longer seeking to rhythm control, we would give them rate control in the form of either a beta blocker, or if this was contraindicated, we might consider a calcium channel blocker or digoxin. In patients who have persistent atrial fibrillation, patients who we do want to rhythm control, and when I say that, I'm referring mainly to younger people who would benefit from being in normal sinus rhythm, we would use an antiarrhythmic method of controlling their atrial fibrillation. If they had been in atrial fibrillation for less than 48 hours, we would have the option of DC cardioverting them without putting them on anticoagulation. If they had been in atrial fibrillation for more than 48 hours, if their CHADS-2 VASC score was 1 or greater, you would anticoagulate them for 3 weeks before bringing them back and DC cardioverting them or giving them an amiodarone infusion. With all these patients with atrial fibrillation, you will give an outpatient referral to cardiology and you will organise a transthoracic echo for them. In patients who are refractory to multiple DC cardioversions, they may ultimately be considered for an AFib ablation procedure.
Thank you so much for listening to our episode this week. To get the most out of this podcast, check out our Anki flashcards and our Notion document. For all your first principles, keep it right here at 1 p.m.